Hello everyone, this is Alina Isaac moderating today's session. Today we are on the second cycle of infectious disease module, and today we have an eminent faculty to talk about quantitative measures in antimicrobial stewardship. Let me welcome Dr. Satyanarayana Reddy Baigari. He is working as an antimicrobial stewardship pharmacist in Amrita Hospital and Research Center, Faridabad. His key areas of interest are pharmacokinetic and pharmacodynamic principle of antimicrobial dosing and antimicrobial stewardship. He have been working with ICMR and other eminent institutions for the past 1.5 years. So without a delay, let me welcome the speaker, Dr. Satyanarayana. Over to you, Dr. Satyanarayana.
Yeah. Hi, very good evening. Is my voice audible?
Yes, Satya, you're good to go.
Yeah. Thank you for Thank you for your kindful introduction. Without any delay, today I'll be talking about quantitative measures of antimicrobial stewardship. Uh, Before that, I don't have any relevant financial relationships with commercial interest. And yeah, today learning objectives would be about why these metrics have been introduced to antimicrobial stewardship. Next, what is the motive behind adding these numericals or arithmetics to antimicrobial stewardship? What are all the different kinds of metrics we have why we'll be following is in this antimicrobial stewardship, and what are all the calculation parts, and what are all, how they need to be calculated, and what is the motive behind this calculation part. And last, we'll be dealing with antimicrobial resistance and consumption literature. Till now we have. Yeah. First, let us know what does this metrics mean and why this is correlated with antimicrobial stewardship. Here we can correlate with three parts. See, metrics are nothing but it's a quantitative measurement of something that we are trying to correlate with our working. So here we'll be dealing with antimicrobial consumption. So this metrics would be dealing with measuring of antimicrobials that would be helpful in knowing the prescription trends and also prescription patterns in particular location or region or institute. So by that we can follow up with the antibiotic utilization review, which would be giving you a complete picture. So this is the complete meaning and complete relevant thing for adding this stewardship with metrics. And what is the motive behind adding these numericals to antimicrobial stewardship? As I mentioned earlier, we are dealing with quantitative measurement. So, as we are dealing with quantitative measurement, we need to get an outcome for it, because when we are working on one process or one kind of implementation, we also need to calculate the clinical outcomes. So, then we can measure to what extent we are improving and where we are standing, and to what extent we can still grow to. So, this would help in coming across all these things. So, that is why it would be helpful in monitoring plus measuring the antimicrobial consumption and also antimicrobial resistance. Here we will be correlating with antimicrobial consumption with antimicrobial resistance, which would be acting as a driving force. And next thing, it is also used as an important pharmacoepidemiological aspect, which everyone knows, like we'll be comparing the data with regional, national, and also international, so that we can understand where we are standing and what are all the limitations we have and in which way we can still look forward. Yeah. Uh, in this metrics part, we have different antimicrobial related metrics. First, antimicrobial prescribing rate. Next would be, we'll be talking about defined daily dose or daily defined dose. And third would be prescribed daily dose. And fourth one would be days of therapy. And next, length of therapy and cost of therapy. And this AWARE classification that was introduced by WHO. Standardized antimicrobial administration ratio. And finally, antibiotic related length of stay. So these are all the metrics part we'll be discussing now. First, let us start with antimicrobial AWARE classification that was proposed by WHO. So, as per WHO, the list of antimicrobials were categorized into three categories. One is access group, watch group, and reserve group. So when we talk about access group and watch group, these would be acting as an first and second line drugs for treating the infections. And this is having a benefit that these are all having less chance of developing resistance. So that's why we will be starting with this. And the last one would be reserve antibiotic group. Here, these would be used as a last resort option for MDROs because these would be having a more chance of developing resistance by the bacteria. And this is a resource that is available as in literature to refer what are all the drugs that fall under aware, what are all the drugs that fall under watch group, and what are all the things that fall under reserve group. So this is the list of antimicrobials that are mentioned as per the WHO aware classification. And again, this tool would be useful for better supporting of antimicrobial monitoring and taking care of stewardship practices. So we can deal with metrics part here. So this way it would be useful as a tool. Yeah. If you come across this WHO website, there would be one common code that would be used for denoting each and every antibiotic. That is called ATC code. ATC nothing but anatomical therapeutic chemical code that would be given for each and every antibiotic or antimicrobial to know the or to indicate the particular thing with an definitive code that is given by or proposed by WHO. See, here the common thing that we'll be noticing is this J would be the common code that would be used for indicating anti-infectives for systemic use. And to make it very precise, J01 is a code that is useful for antibacterials that are used for systemic use. And terms that are, I mean, this is another way of again making it much more precise. And next one, J01D. This deals with other than beta lactams and followed by to indicate that particular antibiotic, it again would be having another tag or the last ending three letters or the three digits would be denoting particular antibiotic. So this is the way they will be differentiating from the initial anti-infective category to particular antibiotic. So this is the proposed way by WHO. If you notice this, antimicrobial agent have one first important thing. Every antibiotic would be having this code. But the issue is there would be few antibiotics where the ATC code would be given based upon its route of administration and also for the purpose of indication it is used. For example, if you take, we can make it very clear with this ciprofloxacin. The ciprofloxacin, when we are dealing with IV thing, then the DDD of ciprofloxacin, while it is given in intravenous, would be 0.8 grams. But when we are going ahead with peroral choice, then the DDD proposed by WHO would be 1 gram. So this way it differs based upon route of administration. And next one would be based upon indication. This metronidazole, this would be having two DDDs as per its indication. That is, if you are dealing with anaerobic coverage, now it would be 1.5 gram per. I mean, this is a DDD that is given by WHO. And the next one would be if the indication is covering for antipyretic, a parasitic thing, then the DDD of an metronidazole for 1 gram for 1 day would be 2 grams. So this way it differs with antibiotic, route of administration, and indication. Yeah. Now let us start with daily defined dose. The common definition that everyone used to represent is it is an average daily maintenance dose for drug used for main indication in adults. First, let us talk about the advantages about it, and also later we'll be talking about the limitations of it. So when you are talking about advantages, it would be very good benchmarking aspect to talk about the metrics of an antimicrobials as it is advised by WHO, and also this is having a good kind of advantage. That is, here we doesn't require any kind of administration data from audit or nursing charts. We'll be getting it from the pharmacy counter or the pharmacy administration. All these departments would be useful for getting the data. But one more thing we need to keep in mind is we need to have an electronic support to get it. And next thing, it would be also useful for dealing pharmacoeconomic analysis, which would be one more important aspect to deal with cost of therapy during the hospital stay. And the limitations of this would be, as it is an WHO assigned thing, it is very tough to deal with the countries that are not following this one, because the CDC and the IDSA are saying DOT would be the probable one, which would be significant for measuring the consumption of an antimicrobials. And next thing is, this DDD is not suitable for pediatric patients, because the WHO haven't not yet defined a pediatric DDD for antimicrobials. And next thing, the DDD code, I mean the ATC code was not designed for all topical antimicrobials. This is one more limitation when we are dealing with DDD. And next thing, when we are dealing with the renal patients, it is tough to calculate because we'll be adjusting it as per the renal clearance. Again, here the DDD is nothing but the WHO has already given a benchmarking for one day what would be the average maintenance dose that would be required for a patient for particular indication. So when we are dealing with renal patients, we will be adjusting the dose as per the creatinine clearance. So there we will be having a limitation. That is why we'll be calling as an a few cons that are related to this. Yeah. Let us talk about the basic formulas that are used for calculating DDD. First, to know the basic DDD, first we need to calculate the amount of antimicrobials in grams that would be divided by this WHO defined DDD value. For every antibiotic, the WHO has been given one standard value, which would be acting as a constant. And next, DDD for 1,000 patients per day. Here we will be calculating using the hospital DDD. I mean nothing but the value that we attained in the first step would be used as a numerator, followed by number of patients for a particular time or specified time. We'll be considering as a number of patients, and then followed by duration. Like if you are dealing or if you are calculating for 1 month, it would be 30 days. If you are calculating for 3 months, it would be 90 days. If it is 1 year, 365 days. So in this way, we'll be mentioning the duration in number of days into 1,000. This would give you DDD per 1,000 patients per day. And if it is DDD per 100 bed days, now same. The numerator would be the one which we got in the initial step, and the bed strength, it would be like maybe this would be done as per the ward, or it may be considered as an hospital. Anything you can consider as per the institute aspects. So again, here the bed strength depends upon the way you prefer, but most probably we will be doing like it as an ward wise, like MICU, general ward, CTICU. So this way it would be very precise and would be very good data. And then duration would be same again, like it would be for 1 month, 3 months, 6 months, whatever it may be. We need to convert that into days. And occupation and occupancy index would be number of beds that are present in particular ward and number of beds that were occupied in particular specified time. That defines the occupation index, and we'll be completely multiplying that with 100. Yeah, occupancy index would be like occupied beds over a period of time, dealing with bed strength for a particular period of time. It would be very clear if we can correlate with the metrics now. So let us do an activity. For example, an individual antibiotic DDD, take it as a meropenem, that 2 grams that was advised, like 2 grams administered 3 times a day and given for 21 days. So the WHO meropenem standard value is 3. So now when we calculate the DDD per day, it would be like we need to first consider what is the dose per one time. It is 2 gram plus how many times we are giving per a day. It's 3 times. So it would be totally 6 grams. 6 grams divided by 3, the one which we start just uh, indicated here. I mean total amount of drug over period of time by WHO given DDD value. So this is the way how we will be dealing with the first step, and the answer would be 2 DDD. And when we are calculating for 21 days, then we need to just calculate, I mean 21 into this 6 would be 126. And again we need to divide it by the standard value of meropenem, which would be 3. that would give 42 DDD per 21 days. Yeah, this would be very precise. So here we'll be talking about each and every parameter that we just discussed in the formula. So consider like as an hypothesis, we are calculating the DDD of a meropenem for a year 2022, and the bed strength of an ICU would be 45, and also the meropenem DDD per year of 2022 is 3642, and the number of patients are 8459, and this will be getting from administration or the quality department, and the duration of time is like 365. We are calculating per year, right? So here it is 2022, as we are calculating per year, it's 365 days. And number of occupied beds in 2022, that is 8910. This is also we can get from administration department or quality department. And also the total bed strength of an year 2022, it's 16,425. So these are all the basic information we need to know before starting or before doing this DDD. See, now we are calculating the DDD of an meropenem per 1,000 patients per day. The same thing. First, we need to know what is the standard value we got here. So now we'll be calculating that 1.2 DDD per 1,000 bed days, because here this is a value that we got this way. Here we'll be giving this taking this variables. For example, the number of DDD of an year of meropenem is 3642 divided by, again we'll be taking number of patients, because as per formula we'll be first dealing with what is the meropenem annual data, followed by what is the patient inpatients, are what are all the patients, who are all the patients admitted in the hospital per particular specific time, and then the duration would be 1 year we are calculating for, so it would be 365 days, and we'll be multiplying with 1,000. So the value of this equation would be 1.2 DDD per 1,000 patient per day. And next, when we are calculating the DDD per 100 bed days, it would be the same. We'll be taking the standard meropenem DDD of an year 3642 by 45 is like bed strength. We discussed here about the bed strength, right? uh, Yes. Here, if you consider this formula for calculating 1,000 bed days, we are correlating bed strength into duration into occupancy index. So the same way we'll be correlating with the equation. So here we are taking 3642 into the bed strength of the particular ward or area, and the duration is 1 year, followed by what is the occupancy index that we'll be getting from this. Occupancy index is nothing but the total strength they are describing is 16,425, and the number of occupied beds in the 2022 is 8910. So we'll be taking these occupied beds as a numerator and the total occupied strength as a denominator, and the ratio or the value that will be obtained here is used here for calculating the equation. So in this way we'll be doing the activity. And if it is DDD per, this is the one that the same thing where we have just discussed about the complete data or complete numericals. Here we'll be talking about this. Mostly the DDD would be calculated as per 1,000 patients per day, or if not 100, I mean DDD for 100 beds, 100 bed days. So this is the two ways we'll be following for calculating the DDD. But the most preferable one would be 100 bed days, and this is also one of the equation that few countries are following. And what are all the tools or what are all the minimum variables we require for calculating this DDD? First thing, the common two tools used are MS Excel based thing. If not, WHO AMC tool, nothing but antimicrobial consumption tool. So the variables are, for example, regarding patient, we need to have all these demographics. For example, what is the age, gender, admitted location. This admitted location gives us to be very precise about the area or ward or the kind of patient where the patient admitted. It would be giving very precise data based upon the departments also. And also here we have department and also doctor wise. This data can be given in a 3 to 4 ways, like physician wise, department wise, if not the ward wise, I mean locality wise. So it would be based upon the institution how they proceed to. And it is if it is regarding the drug, we'll be needing the information about generic name. Always we need to use the generic name, not the brand name. So this is the one more thing we need to keep in mind. And we also need to take what is the start date, how many number of vials that are dispensed, followed by what is the strength of each vial, and what is the WHO DDD value of particular antibiotic. So this would be the way how we will be representing on Excel sheet. So the same way which I mentioned, like demographics, where the patient admitted, what is the day of admission, what is the antibiotic, that too in generic name, followed by how many vials, what is the strength of each vial, and for calculating this, we can use the pivotal graph or pivotal Excel sheet so that it will be easy for calculation part. And the WHO DDD value constant is 3. I mean the constant value. And now what is the hospital DDD? Like 2. We are just multiplying it, dividing it by the total number of, we are dividing this 6 by this WHO DDD value. So this way we'll be getting that value as an 2. Yeah, it would be this complete data. You can get it from the pharmacy or hospital formulary. If not, even you can get it from the administration department. This is one more thing that it would be useful for, I mean, as I mentioned earlier, we can do monthly wise or quarterly wise or 6 months once or annually once. So this way it depends upon based upon the institution how it would work. It would be the preferable one would be mostly monthly. If not, at least it need to be done quarterly. This is about the second way using AMC tool. So for using this AMC tool, we require all this data or all these variables. For example, if it is a drug related thing, we need to have a generic name because we need to represent with generic name, and also what are the total number of vials that were dispensed, what is the strength of each vial. This would be about drug. And if it is about patient days, like we need to know about where the patient admitted, what is the strength of that particular area, how many days the patient were there, and what is the occupancy index. And next one, the last one would be about if you are calculating for 1,000 patients per day, then it would be number of patients and number of days. Number of days in the sense that particular specific period of time that we are going to calculate. Yeah, this is a portal that would be available on Google. So this is available from anyway. You can use this common link that would be directly directing you towards the home page. So it is also suggested by WHO. Now let us talk about DOT. DOT is nothing but days of therapy. Here will be the DOT is defined as very simply like total number of days the patient on antimicrobials, irrespective of dose and frequency. So here we will be calculating the DOT of an each and every antibiotic. So this would be much more precise one. Yeah, before going into deep, let us talk about what are the pros and limitations for this particular DOT. As it is suggested by IDSA and SHIA and CDC, it is one of the important to participate in CDC survey or any CDC related studies. And followed by, this is also useful for taking the data from pediatric wards or pediatric departments. And next one, there are no such kind of discrepancies between this WHO assigned and followed by the CDC, because here we are taking each and every antibiotic into consideration and we are calculating the total number of days. So this would be the benefit we have. And what are the limitations? If we come to limitations part, the only particular issue is whenever we are dealing with renal patients, it would be very tough because if a patient is on hemodialysis or if a patient is on any kind of peritoneal dialysis, will be the patient would be receiving antibiotic only in alternative days, or if not any like every 72 hours or every 36 hours. So during this kind of scenarios, it would be tough to follow up. So this would be the one of the limitation of it. And the next one would be, as many countries are following this DDD as a standard tool, so it would be one kind of challenging to deal with this. So these are all the most probable limitations. And one more important is, for this collecting data of DOT, you need to have electronic health records. Unless and until if this is not there, it is very tough to follow up with the DOT data. Yeah. As I mentioned, there is a different formula that is suggested by WHO and CDC. If it is WHO, there the main difference is they are saying like it should be considered as a total patient days for specific period of time. And if it is CDC, they are mentioning like total number of days present. So total number of days presents or admissions that are only restricted to that specific time. If it is monthly, if it is quarterly. So this would be the way we will be dealing with the considering the variables. Yeah. If we know, or if you talk about this basic formulas, same thing as previously we discussed about DDD, the same way. First, DOT is nothing but the total number of days on which the patient is on antimicrobials, and followed by that would be related to specific period of time. Again, it would be monthly, quarterly, or 6 months once, the same way. And next, if it is DOT per thousand patients per day, then here we'll be taking this hospital DOT as we'll be calculating as a common one. Like we'll be counting the total number of days the patient is on particular antibiotic, because here DOT deals with each and every antibiotic, not the whole sum. So next, followed by number of patients per particular specified time. And next, what is the duration, like monthly duration? If it is monthly, 30 days. If it is quarterly, then it would be 120 days. If it is 6 months once, it would be 180 days. So this way we'll be considering duration as per the months into 1000. And if it is when we are dealing with 100 bed days, then it would be like completely different scenario, but the same formula would be related to DDD. Like first we'll be considering bed strength, what is the particular duration, and what is the occupancy index, and into 100. So this is the way we'll be considering the variables to do this equation or to solve this equation. So let us make this very simple. So with this activity, I hope you'll be understanding very easily. First thing, if a patient is admitted into hospital, and if he is on antibiotics, consider like if a patient is on three antibiotics. One is piperacillin tazobactam 4.5, meropenem 1 gram, clindamycin 600 mg. So here, as we mentioned, we will be dealing with each and every antibiotic and its DOT. So for example, if you take the piperacillin tazobactam, it is from day 1 to day 3. So nothing but the DOT of an piperacillin tazobactam for this particular patient would be 3. In the same way, if it is for meropenem, the meropenem was started on third day, followed by it was continued till the last day, that is 10th. So now it would be like 8 days. And next, if you are taking this clindamycin 600 mg, again it is starting from the day 6th to 10th. So here we'll be again considering from 6th to 10th, it would be like 5 days. So this is the overall DOT for each and every antibiotic that were used for this particular patient. Again, one thing, the DOT won't depend on dose or frequency. Here we are going with each and every antibiotic. So that's why we need to calculate individually. Yeah. This would be kind of LOT is nothing but a much more same similar to this DOT only. But always remember, here we will not be dealing with different antibiotics. Here the whole would be considered as an LOT. For example, even though the patient is on 3 antibiotics or 4 antibiotics, we'll be just counting the number of days the patient receiving antibiotics. So it is irrespective of antibiotics, dose, frequency, and also how many, and like different variable number of antibiotics. So all these would not be the inclusion criteria for counting the LOT. Only the number of days. So that's why it is called as it would be similar to DOT. And better than this, DOT would be the better one because there will be getting very precise data about each and every antibiotic. So that's why we will be calling as an DOT can be, LOT can be DOT, but DOT would not be considered as an LOT. It would not be similar. And next thing, what are all again, like we discussed previously about this DOT and DDD, what are all the advantages and limitations? The same way this LOT also has. If it is LOT would be like the value would be similar to the DOT, if not even less. And this is the one kind of method that was suggested by the literature. If if you compare the DOT and LOT ratio to identify whether a patient is on monotherapy or dual therapy, I mean combination therapy, this would be the equation that they will be using. If DOT and LOT ratio is equals to 1, then it is considered to be the patient is on monotherapy. And if a patient is on combination therapy, then DOT and LOT ratio would be greater than 1. So this would be one simple kind of hypothesis to identify whether a patient is on monotherapy or combination therapy. So let us make it very simple with an example. Take it like ceftriaxone 5 gram, sorry, 5 days it was given, that is 1 gram, an average one that everyone would be preferring. The DOT would be 5 days. When we compare the LOT, it would be also the same, like 5 days. So if you take the ratio, it would be almost 1. So there is no such issue that uh, so there would be no such difference that if there is no difference between one, I mean this DOT and LOT, then the ratio would be equals to 1. It is called monotherapy. But when it is when a patient is on dual therapy or combination therapy, the ceftriaxone plus metronidazole. So if you take this, consider like the patient is on ceftriaxone for 5 days and on metronidazole for 5 days. So if it is so, here we will be again dealing with DOT, we will be dealing with individual antibiotic and its duration, right? So that's why we will be counting ceftriaxone as in separate 5 days and metronidazole as in separate 5 days. So whole we will be getting as in 10 days for this DOT parameter. But when it is LOT, it would be most probably the 5 days, because here we will be calculating the number of days the patient on antimicrobial therapy, irrespective of number of antibiotics, dose, frequency, and also duration. So if the ratio is greater than 1, it is a monotherapy, combination therapy. This is a kind of small hypothesis that was suggested. And next one would be this DOT, this LOT, they are confirming that it is very difficult to compare with DOT because this DOT would be more precise regarding antibiotic. But LOT would not be more precise regarding antibiotic, because here we are taking an wholesome data of an patient uh, drug regimen. So that is the limitation we have here, and followed by this hypothesis of combination is also one limitation. It's not supporting in all criteria in all the cases. So this is one more thing. See, for example, the same example I'm using. If a patient is on 3 antimicrobials, and if a patient have from first to third day, if a patient is on piperacillin tazobactam, then from third day to 10th day, the patient is on meropenem, plus from 6th to 10th, the patient is on clindamycin. So here the whole sum would be as a meaningful LOT value. So that's why the LOT is considered as an 10 days of an antimicrobial therapy. So here we are dealing with complete duration from the beginning day to the last date. Here we are not comparing separately for one particular antibiotic. So that's why the more precise one would be DOT. And how we mark this DOT in Excel sheet. So same like DOT, DDD. First, we need to have patient demographics, followed by in which location the patient admitted, and the third one would be what is the antibiotic, and that need to be represented in generic name. That would need to be represented with generic name. And what is the start date? What is the end date? So by subtracting from the day of beginning to from the day of discharge, we'll be calculating the duration. This gives the DOT. Yeah, as we discussed earlier, this DDD, DOT, LOT, all these can be mentioned or presented in a graphical way, if not the tabular way, I mean tabular column. So it can be done in four different ways. That would be like unit wise, if not drug spectrum wise. I mean, you can consider all gram positives or all gram negatives or anaerobic coverages. So if it could be this way, if not population specific, population in the sense again all pediatrics, all general medicine, all males or females. If not, we can take even disease, like when we are comparing only the sepsis patients, or when we are dealing with only urosepsis, or only the alone respiratory. So this way we can do in these four possible ways to calculate the DOT as per monthly or biannually or annually. Yeah, this is a tabular way of presenting. This is 1 year data of reserve antimicrobials as per the institute. So this is the one way to represent. This we follow tabular column, and you can prefer this graphical way of representation too. Yeah, to make it very nutshell, the DDD talks about the average maintenance dose that is given for particular indication in an adult patients. So that would denote DDD. But when it is DOT, here we will be measuring the number of days the patient on antibiotics, and that would be respective with each and every antimicrobial in the regimen. So this is a way of dealing with DOT. And if it is LOT, here we will be dealing with total number of days the patient receiving antibiotics irrespective of drug, dose, frequency, and all. Thing, because basically the hospital or the hospital management would be spending lots of money for purchasing this antimicrobials. So this is also one of the important aspect we need to measure. So the cost is calculated in a standard rate card. This would be again a kind of, it would be again used for comparing the epidemiological survey, and also to get compare with the global data where we are standing, and followed by how we are and also we can make an outcomes and also methods to identify the cost reducing way of dealing with healthcare economics, which would be one of the important factor. Like everyone knows how this pharmacoeconomic factor would be important in decreasing the hospital stay, decreasing the economical burden, and enhancing the patient safety. And this cost of therapy is also one of the GDP growth rate for this is most probably seen in lower income countries, and also this middle income countries. And the difference, the one of the limitation for this criteria or this cost of therapy is it again deals with it again differs with country, the economical status, followed by how this each molecule is ranging from country to country, company to company, I mean pharmaceutical industries. So this would be the limitation for this cost of therapy. And next one would be, uh, see, this is a reason why we are tracking this antimicrobial metrics as an important factor, because the reason why we are calculating this are to know the compliance rate, to which extent or to what level we are practicing and following the rules that we have framed as per the global, regional, or the national thing. So which would be helpful in getting the data, and followed by it would be also helpful in knowing what are all the antimicrobial prescribing patterns of particular locality or institute or nationally. So all this would be useful for comparing data based upon the regional wise. And next, the the main aspect is, if you can't measure the outcomes of this antimicrobial metrics, we can't know where we are standing, and we cannot understand what are all the prescribing practices or patterns that are respective to the institute. So if you are not knowing this, we can't improve. So just for numbers purpose, we are not dealing this. We are doing this to improve and to enhance the quality. I mean, these quantitative things are directly proportional and directly linked with quality of an antimicrobial stewardship. So this way we can correlate this metrics part with antimicrobial stewardship. And this is the one of the report that was given by WHO. Here it would be talking about this report is called GLASS report, nothing but Global Antimicrobial Resistance and Utilization Surveillance System. As this would be this GLASS report would be giving what is the antimicrobial resistant rates all over the globe, and what is the antimicrobial consumption rate all over the globe, and how this relation between antimicrobial consumption and antimicrobial resistance is dealing with, and how the resistance are increased. So all this report talks about all these things. First thing, if you consider this image, the blue ones are considered to be the countries that are enrolled for both antimicrobial resistance surveillance and antimicrobial consumption surveillance. This purple would indicate the list of countries that were enrolled for following antimicrobial resistant rates, and the orange ones represent that countries that are enrolled for uh, I mean collecting the data regarding antimicrobial consumption. And next, this white color indicates the countries doesn't enrolled to anything. So this is a way we will be differentiating. As per this report, our India is only enrolled in antimicrobial resistant rates. Still, it is not registered or enrolled under AMC, I mean antimicrobial consumption. The consumption is very important because the consumption act as a tool to know how these irrational things are promoting the antimicrobial resistance. So that's why the consumption data is very much important, and nowadays even many countries are giving attention to it. And now there are few more companies which would be doing surveys, like ICMR is working on it, followed by IQVIA is working on it, followed by this WHO is working on it, and also CDC. So there are many organizations now these days started giving attention to it, so that we can improve this antimicrobial consumption, so that if we can promote this consumption rate in a rational way, so that this resistant rates would be coming down. So this is the main point of comparing two things and making outputs from it. Yeah, this is a IQVIA study that was done in 2017. They targeted lower middle income countries, and how this AMR and AMC are giving kind of impact on GDP rates, and followed by how they are giving trouble in dealing with antimicrobial resistance. First thing, as we discussed now, the antimicrobial resistance would be increased because of irrational use. So if we can make this consumption rate to an optimized level, or if we bring down it to an optimized level, this resistant rates would be bring down. I mean, it can be brought down. So here this report talks about how the GDP growth in lower middle income is also linked with urbanization that facilitates transmission of infectious diseases. So this is the one factor. And one more thing, antimicrobial consumption is higher even when antimicrobial disease burden is high. So the same thing, if we are using antimicrobials irrationally, then the burden of infectious diseases and followed by the resistant rates would be increasing. So regarding these two, the survey was done, and the literature talks about these 2 points mainly. Yeah, these are all the references that I quote for this presentation. I'm good to go if there are any queries. So I end my presentation to here.
Hi, Satya.
Yeah,
Wonderful presentation, sir. Satya, you have covered the topic very comprehensively.
thank you, thank you.
So, like, we have two questions.
Yeah,
Can I proceed?
yeah, please go ahead.
Okay, you discussed about DDD, DOT, LOT, etc.
Yeah,
So we have a formula for DDD by CDC as well as by WHO.
Yes.
Is there any criteria or instruction to use which formula when?
Yes. See, most probably, if it is CDC and if it is WHO, the first thing is the WHO is the most prominent one and it is followed by many countries. That is the one thing. And when we do deal with DDD, there are limitations. That is, we can't get a rational data from pediatric population, from renal insufficient group of population, from hepatic insufficient group of population, if not immunocompromised group of population. And again, there are few antibiotics where this even DDD, WHO haven't given, till now they haven't given any ATC code. So if there is no ATC code, we can't calculate. So there are more limitations for DDD than DOT. The rational one would be DOT. DDD would be followed by this US and all this WHO related, I mean WHO parameters following countries. But DOT would be more precise because even if there are any this dose challenging things, we can consider because the patient would be an antibiotic. So we can consider the number of the number of days the patient exposed to antibiotics. And next, one more plus point is even in pediatrics we can calculate. And also the advantage about it is this would be more precise one, like we can deal with each and every antibiotic. We can even identify where the irrational use is going. Is it regarding access group, or is it regarding watch group, or is it regarding a reserve group, so that we can identify what is exact problem and we can start working on it. So it would work more better than DDD. DOT would be the better one. So this way it would differ.
Okay, so there is
I
no
hope I
particular.
answered your query.
Pardon?
I hope I answered the query. Let me know.
Yeah, you did, Satya.
Yeah.
Another query that was raised, like you
Yeah.
you were discussing about quantitative outcome measures to measure the antimicrobial stewardship projects.
Yeah.
So, like, how could that qualitative outcome measures could impact in this measurement, and overall how it is going to affect the AMSP program?
Okay. Thank you for the nice question. First thing, if it is quantitative, here we are measuring the metrics. I mean, before we know, for example, quantitative would be the amount of drugs or the amount of the consumption of antimicrobials that are used in a region or institute nationally or globally. This would tell to what way we are using. So again, we can, for example, if antimicrobials are used very irrationally, then the consumption rate would be, I mean, it would be going up and down. So this again will promote antimicrobial resistance. So our complete motto of working or implementing antimicrobial stewardship is to bring down the antimicrobial resistance and to promote antimicrobial prescription ways of prescription in a rational way or optimized way. So when this can be first time of this AMSP is to bring down antimicrobials and to promote optimized use of antimicrobials. Sorry, to bring down antimicrobial resistance. I'm sorry, so that the first issue would be sorted out. And the next one, it would be when this quantitative metrics or quantitative clinical outcomes are improved, the quality would be regarding, again, for example, if you correlate this DDD, DOT and LOT, if not this prescribed average prescription dose per day, all this would denote how precisely or how rationally each and every antibiotic was given for particular indication and the particular duration for the particular patient based upon the clinical condition. So this way, the quantitative would be directly related to qualitative because the consumption and resistance are both need to be, I mean, addressed. If these two are not addressed, if anything among these two is neglected, I hope it would not be justified. So that's why I think like these two are main attention for this AMSP.
Okay, Satya. So with this, I think we can end the session. I hope all
Okay.
the budding pharmacists and practicing pharmacists would be highly benefited with the session, like especially in the beginning of their antimicrobial stewardship program at their own institution. So, dear viewers, thanks for watching and listening to us. So, catch you with the next video. Thank you.
Thank you.